this presentation really is to get everybody in the mindset that yes, it is very important to train your embryologists in embryo biopsy, but PGT is not a treatment that is isolated to the embryology lab. It's a clinic-wide introduction, and there's a lot more than embryo biopsy that we need to think about. You've got to train all of the staff in the clinic just as you do with any treatment. You've got to have your patient information, you've got to be obeying the regulatory requirements for your country, you've got to have specific SOPs and policies in your clinic surrounding genetic treatment. You've got to choose the genetic provider that you're using. It may be somebody internal, or you may have to use an external genetic provider. You're also going to have to think about actually giving genetic results to the patients, validating, verifying, qualifying your service, and also monitoring your service once it has been introduced. Are you getting good results? If you're not getting good results, why are you not getting good results? So embryo biopsy is really only a very small part of actually introducing this treatment into your clinic. And it's normally the easiest part as well, because embryologists are very used to having to learn and introduce new technologies and techniques into the lab. And it's normally the rest of the infrastructure that takes a lot more thought and planning. And it is worth the thought and the planning, because otherwise you have scenarios that you haven't thought about occurring when you've got a patient in front of you. So the regulatory requirements obviously differ from country to country. Even within the EU, there's no common legislation in terms of reproductive technologies, and this includes using genetic testing to select your embryos. So depending on what country you're in, you need to make sure you know and are obeying the regulatory requirements. It can be that you're restricted under license to what can be performed. There can be restrictions on what centres are actually allowed to provide the testing. There can be restrictions on what information you can actually release to the patient. For instance, the UK does a lot of testing, but we don't release gender. There can be restrictions on which patients are allowed to access the testing. There can be restrictions on what material the people in the lab are allowed to use for training. And there can also be restriction on what embryos can be transferred. For instance, in the UK, there's nothing that says you have to transfer a healthy embryo. What is said is you cannot prefer an affected embryo over an unaffected embryo. So you can't have somebody in the UK come and say, I want to have a child with the genetic condition, but if they have no healthy or unaffected embryos, you are allowed to put back an affected embryo. So you need to know what the regulations are in your country, and sometimes they can be logical, and sometimes they can be things that you haven't thought about. For instance, hidden in the Code of Practice in the UK is a regulation that says you cannot transfer a biopsied and an unbiopsied embryo together. So some of the regulations are common sense and will be very apparent, but some of them might be hidden in regulation, and you need to make sure that you know where to find the regulation and that you are sticking to it. When I talk about deciding on policy, this is largely to do with the clinical side of treatment. So your doctors will be having a clinical policy that in terms of how the cycle treatments are set up. So you're thinking about what day are you going to be doing biopsies on. Obviously, historically, biopsies have been done at the polar body stage, at the day 3 stage, cleavage stage, and also at the blastocyst stage. And when we go back to regulatory requirements, certain countries can only do polar body biopsy, blastocyst biopsy, and cannot do cleavage stage. So these things sometimes feed off each other. You also need to think about if you're doing a fresh or a frozen transfer. You need to think about what genetic testing you're actually doing. we've got PGT-A, which is chromosome aneuploidy screening, and we've also got PGT-M and PGT-SR, which are PGD for heritable conditions. But even within those different types of PGT, there are different technologies which are used. So what technology is your genetic provider using for the testing? And that's very important as well. What information is the lab going to report to the clinic, and what information is the clinic going to give to the patient? A good example of this, as I said, is gender. Another example is from chromosome testing mosaic results. Some clinics are still not comfortable in communicating mosaic results to patients. And one of our scientists will be speaking about that tomorrow, about communicating mosaic results to the patients. Again, as I said about mosaic and affected embryos, what embryos are you going to transfer? Because it's always a Saturday when you've got a difficult case and somebody says, are we allowed to transfer this embryo? And that's where it is useful to have everything thought about and written down in policy beforehand. Will you transfer embryos which are mosaic? If you've got a patient that has no unaffected embryos, will you transfer an affected embryo for them? I know that sounds like quite silly. Obviously, if you've got somebody with a muscular dystrophy or a cystic fibrosis, you're not going to transfer an affected embryo. But maybe if you're testing for BRCA and you've got a male embryo which carries the BRCA mutation, some patients would be quite happy to have that embryo transferred if that was the only option. You've also got to think about your patient criteria in terms of ovarian reserve, AMH. Are you going to have cut-offs for age and fertility for the patients you're going to offer the treatment to? And what type of stimulation protocols are you going to use? If you are doing frozen cycles, are you going to more aggressively stimulate the patients to get a higher egg yield? If you're working in a clinic that doesn't have many biopsy practitioners, it may be very important when you schedule the egg collections and the biopsies for these patients. So it may be necessary to say, okay, we're always going to use a long protocol so that we can schedule these patients rather than using short protocols. And the frozen embryo replacement protocols are very important as well, and both for maximising the pregnancy rates when you are doing frozen transfers, but also to minimise the chance of a natural pregnancy. There's many PGT-M cases which were initially thought to be misdiagnoses, which ended up being proven to be natural conceptions. So many clinics, when they're doing FERs, will only use protocols where they're less likely to see development of follicles. And if they do see a development of follicle, they cancel that cycle. So these are all things to try and think about and lay out in advance. You've also got a lot to think about in the embryology lab beyond just introducing the embryo biopsy technique. One of the most important things, especially if you're going to be doing biopsy at the blastocyst stage, is to optimise your blastocyst culture. Because if your embryos are not going to be blastocyst stage, you're not going to have embryos to biopsy, and you're not going to have good clinical results. I remember 15 years ago when it was really exciting to see a blastocyst, to then when I was last working in the lab about a year ago, if we had any patient that didn't have a blastocyst, it was a disaster. It was something that we needed to discuss at the meeting. Why did this patient have no blastocysts? Because our blastocyst culture has really, really improved over the years in terms of our incubators and in terms of the media that we're using and the environment that we're able to provide within the lab. And I remember when we started to introduce blastocyst culture, we said, okay, if a patient has 8 good embryos on day 3, we'll take them to blastocyst. Then we thought, okay, that's a bit strict. If a patient has 5 good embryos on day 3, we'll take them to blastocyst. Then it reduced to, okay, if the patient's got 3 good embryos, we'll take them to blastocyst. And by the time I left that lab, the criteria was If the patient has 2 eggs which are fertilised, we take them to blastocyst. And it's really about having the confidence in your culture system to know that if an embryo doesn't reach blastocyst in your lab, it's not a viable embryo. Which is why when doctors will say to me, for this patient I'd like to do a day 3 biopsy because she doesn't make blastocysts, I would say, well, if she doesn't make blastocysts, she doesn't make babies. It's not a viable embryo. But it does take a while to get that level of confidence in your culture system. And the embryologist will generally get it first, and then as once that phase is woven through the results that you get, your clinical team will follow. It's obviously also very important to optimise your vitrification system, especially the embryo survival warning. As embryologists, we're very used to giving bad news to patients, but I think the worst news that I've ever had to give patients is to say, yes, I know you went through PGT or PGT, I know you had an embryo that was suitable for use, but I'm afraid that embryo hasn't survived the thawing process. So we really need to optimise our culture system, that's not a situation that we're putting ourselves in with vitrification. In terms of the culture system as well, we're not just talking about blastocyst culture, we're talking about your culture system within the lab, what dishes you're using and what incubators you're using. So I often like to use the example of if a patient has 5 embryos to biopsy. You open the incubator, you take out your culture dish and move the embryo to the biopsy dish. Then you go back to the incubator, open it, put that dish back in again and go and do your biopsy. Once you've done your biopsy, you go back and you open your incubator yet again and take your dish out and put the biopsied embryo back in the dish and then go back to your incubator and open it again, put that dish back in. So we're really disrupting the culture system, not just for the embryo that we have biopsied, but for all of the other embryos that are in the same culture dish and for all of the other dishes that are also in that incubator. So we need to think about how to minimise the disruption, not just for that embryo and for that patient, but for all of the patients that we have in the lab at that time. And for that reason, people tend to split the embryos between multiple dishes, so that we're not taking the same dish in and out of the incubator, and also use benchtop incubators with compartments, which tend to recover a lot quicker within that time period and only have that patient's dishes, even maybe just one of that patient's dishes in there. The other time we disrupt the culture system for these patients is when we're trying to observe them to see if the embryos are ready to do the biopsy. And for this reason, quite a lot of people will use time-lapse incubation for their biopsy patients, because that allows you to observe the embryo development and to see they're at a stage where they're ready for biopsy without having to take them in and out of the incubator to look at them and see if they're ready for biopsy. Method of insemination is also something to decide about. The ESHRE guidelines obviously still recommend ICSI for any PCR-based genetic testing. The guidelines are currently being reviewed, but increasingly people are using IVF for PGT-A patients at least, and some people use it for PGT-N or PGT-FR patients as well. So if you're going to go against the ESHRE guidelines, you just have to have a reason for doing so. You have to have a risk assessment for why you're not following the guidelines. Hatching on day 3, day 4, or day 5, whether you want to hatch the embryos before biopsy or not. My personal preference has always been to hatch the embryos on day 3 or day 4, so that when I come in on day 5 or day 6 to do the biopsy, the embryos are already herniating. However, some people see that as an extra disruption to culture and prefer to just take the embryos on day 5 and hatch and biopsy at the same time. There's no publications, there's no evidence that says this way is good and this way is bad and the results are better if you do one or the other. So it can be what fits in best to your lab and what's your personal preference. You also might want to set criteria for what to biopsy. because we always do that, we're sat at the microscope and we say, Sally, would you biopsy this embryo? I can't decide. So it's good not to have too strict a criteria. You know, you can look at the grade, you can look at the stage of development, and you can look at the day of the biopsy. From my personal experience, the stage of development is the most important. That the embryo has started to expand to the point that you can differentiate the inner cell mass from the trifectodermal cells. I'm not as worried about the grade, and I'm not as worried about the day of biopsy. And increasingly, we're having clinics send samples in for genetic testing to CooperGenomics, who they have started to biopsy late on day 4, and they've continued to biopsy through day 5, day 6, and day 7. And we have had deployed embryos and pregnancies from embryos that were biopsied on day 7. And also, witnessing is incredibly important. The chain of custody between embryo to trifectoderm biopsy sample to PCR tube to vitrification straw with the embryo in it is incredibly important. If anything goes wrong in that chain of custody, your embryo and the result for that embryo in your report might not match up. So I really can't stress highly enough how important the witnessing is in this procedure. And obviously we've got the RI witness here that Sally can talk you through later. Staff training and education is always good. So as I said, it's not just your embryologists. It's your receptionists and secretaries. They tend to be the first port of call for patients when they're phoning and they have an inquiry. They want to know if you offer a specific treatment or not. The nurses as well tend to be the people that have the most interaction with patients throughout their consultation and treatment period. The clinicians are kind of the most important people in terms of whether patients decide to actually have genetic testing. If your clinicians understand genetic testing and if they think it's beneficial and they suggest it to a patient, the patient will probably have the genetic testing. If you have a clinician who, you know, isn't really sure about PGT and it's like, well, you know, some people do this, if the patient doesn't think that the clinician believes in it, then they're not going to have the treatment. So it's really important to know how your clinicians are communicating these treatments to the patients and what they're telling them. And if they're giving them the right information, it makes it a lot easier then on the embryologists who are then dealing with the patients when they're going through that process of embryo development and biopsy. So this is a question I'd just like to ask, so audience participation. What is the minimum number of training embryologists that an embryologist should biopsy before they're deemed competent? So I'm saying minimum. So they've biopsied this number of embryos and they're perfect. So hands up how many people think they should do a minimum of 10? 20? 50? Who thinks 100? So I can tell you yet again that ESHRE guidelines say 100. And I can tell you I know 0 embryologists who've done 100 embryos. Again, like we said before about the regulatory impacts in your country, it can impact on what you can actually train on and how much material is available to you. Again, my experience being UK based, if we had to biopsy 100 training embryos and we need specific consent from the patient to use those embryos, a unit, even a busy unit, would be lucky to train one practitioner a year. So, generally speaking, most people would say sort of 20, 25, 30 embryos as a minimum. And obviously then you've got to decide when they're doing those, what criteria are you looking at? When you're watching them, when you're going to be training, how do you know that they're competent in that procedure and that they're doing it well? So are they doing it according to the SOP? Do the embryos survive the biopsy procedure? Do you have an intact cell sample? And do the embryos re-expand? So there's a number of different criteria that you can look at, that not just somebody is doing the biopsy and training on these embryos, but that they're actually doing it well. And obviously it's important to continue to monitor the competency of your embryologists, post-biopsy procedure. There's ongoing competency assessments and we're continuing to do it correctly. Choosing a genetics provider, we're not all lucky enough to work within an establishment that already has a genetics lab, and we need to choose who we're going to send ourselves to. So generally speaking, we're looking for someone who's experienced in the field. We're looking for someone who has relevant accreditation. We're looking for someone that has a relevant testing repertoire. And the questions that we need to ask ourselves are, what are we testing for and what is being reported? So for instance, if all you're interested in is gender, then you could go to a lab that just does fish. If you want whole comprehensive chromosome screening and you want information on mosaicism, then you need a provider that's using a validated next generation sequencing platform. So it's very important to know what information are you intending to get, and are they offering a test that's going to give you that. Obviously, you also want a provider that's going to offer support and troubleshooting, and one where it is logistically possible to send the samples. So I have previously been based at the genetics laboratory for CooperSurgical in Nottingham, and most recently we've started getting samples from Australia. So samples can be sent all across the world as long as the logistics are set up correctly. You also want to think about how you receive the results. Who do the results go to? Who communicates the results to the patients? And just really having a provider that you're confident in the communication and cooperation between the embryology lab, the IVF clinic, and the genetics provider. So this is always a contentious point, interpreting and giving the results. So this is where I'm going to ask for your opinion again in terms of who should actually be giving these results to the patients. If it's aneuploidy PGT-A results, or if it's genetic disease results, PGT-M. So hands up, who thinks that it's actually the genetic testing provider that should give the results to the patient? Okay, one person. Who thinks that obviously the patient has their main communication has been with the IVF clinic. So who thinks it should be the embryologist that gives the patient the results? Who thinks it should be the clinician? Does anybody think there's anybody else that should be giving the results? Genetic counsellor, yeah, and increasingly clinics are employing genetic counsellors just for this. So my answer is there's no right or wrong answer to this. It's basically who can pick up that report, read it, understand it, and pass those results on to the patient in a timely fashion. I've always worked in an environment where it has been the embryologists, because the embryologists are there. They're there every day. There's quite a few of us. Whereas our doctors would, and our doctors are very happy with that. And I know it's generally, sometimes I'll sit and if I've got a room full of embryologists, they'll say the doctors should give it, and if I have a room full of doctors, they say the embryologist should give it. So it's always a big bone of contention. But really, the main thing I would say is it just needs to be somebody who's got an understanding of the report and can communicate that confidently to the patient. And that's where most people have the anxiety with mosaic results, because they don't feel confident in how they're explaining it. And obviously, if you're not confident in what you're saying, the patient is going to be anxious with the information that you're giving them. So, KPIs and quality management. You need a plan to monitor your program once it has been introduced, because how do you know if it's working or not? And if it's not working, how do you find out why? So the first thing to look at is your conversion rate from consultation to treatment. And as I said, that's really looking at what are the doctors telling the patients. Because as I said, if the patients aren't getting a positive message from the doctor about the treatment, they're not going to, and you're not going to get any uptake of the treatment. Past that, most of the KPIs are sort of clinical and embryology. So looking at your pregnancy rate is really breaking it down into looking at your biochemical loss rate, your clinical pregnancy rate, your live birth rate, and your miscarriage rate. So those are your clinical indications. In the embryology lab, you're also going to want to look at your no result rate and how many samples, what percentage of samples do you send off that you don't get a result for. Contamination, how many instances of contamination have you had? And then beyond that, it's also interesting to look at what is your euploid versus aneuploid rate, and what is your mosaicism rate. And a lot of people especially monitor these when they're switching incubation or changing culture media and seeing how that affects the metrics that they have. And obviously aside as well, it's very important to monitor the patient survival rates, because if our embryos aren't surviving, we're not going to get the pregnancies. Once you guys have put all of this in place, then we can think about training the embryologists how to do embryo biopsy. And as I say, it really is just to learn from everybody else's mistakes if you're introducing testing into your clinic, and really just to think about overall infrastructure rather than just the biopsy procedure, which really will stand you in good stead for all of the different scenarios that you come across in your clinical and in your embryology practice. Thank you.